Hey everyone, and welcome. Today we're diving into something really fascinating in the world of medical coding: cranial stereotactic radiosurgery, or SRS for short. Now you might think precision is just for the surgeons, but for coders, it's everything. Let's get into it.
So get this. How do you even begin to code for a procedure that's basically brain surgery, but without a single cut? It sounds like something straight out of a sci-fi movie, right? But it's real, and it has its own unique and pretty strict coding rules. Understanding what this procedure is the first step to coding it right.
Okay, let's break this definition down into coder speak. There are a few keywords here you've got to lock in. First, non-incisional. That's your clue this isn't your typical open surgery. Then you have ionizing radiation. That's the tool, a super focused beam of energy. And finally, defined cranial targets. This tells you just how incredibly precise this whole thing is. We're talking pinpoint accuracy.
Now, one of the first things you're going to notice when you see an SRS case is that it's a team sport. It almost always involves two different specialists. And as the coder, you absolutely have to know who did what, because they each get billed for separately.
So here's how it's split. On one side, you've got the neurosurgeon. They're reporting the main SRS service itself, the surgical part, and often the application of the head frame. Then on the other side, you've got the radiation oncologist. They handle everything related to the radiation, the planning, the physics, the delivery, all of that. You'll find their codes in a completely different section of the CPT book. And this is the golden rule you cannot forget. The same doctor can't report codes for both the SRS service and the radiation treatment management. It's one or the other. A neurosurgeon codes for their part, a radiation oncologist for theirs, and never the twain shall meet on a claim form. Seriously, this is a huge red flag for auditors, so burn this one into your brain right now.
All right, so once you know which doctor you're coding for, you hit the biggest decision point of this whole process. This is the main fork in the road, and the path you take determines the code you choose.
And this is it. This is the question. Is the target lesion, the thing they're treating, simple or is it complex? Your entire coding journey for this case depends on the answer. So let's look at how you figure that out.
Here's the cheat sheet. A simple lesion is generally smaller, under 3.5 centimeters, and it's not in a super tricky spot. A lesion becomes complex if it's bigger, 3.5 centimeters or more, or if it's a specific type of lesion, or if it's located in a really delicate area, like the brainstem or right next to the optic nerve. And it makes sense, right? A complex lesion requires way more planning to zap it without damaging what's around it. You'll need to hunt for these details in the operative report.
And here's a pro tip that's going to make your life so much easier. Let's say the surgeon treats multiple spots in one session. If even one of those spots qualifies as complex, the whole procedure gets coded as complex. That's it. Complexity wins. So if you see they treated 4 lesions and 3 are simple but 1 is complex, you're going straight to the complex codes. Easy as that.
Okay, next up, we've got to talk about timing. Specifically, how many sessions are involved in the treatment. This is another spot where it's really easy to get tripped up if you're not careful.
So while a lot of SRS procedures are a one-and-done deal, they can be broken up into multiple sessions. But, and this is a big but, there is a hard limit. A full course of SRS for any one lesion can't be more than 5 sessions. 5 is the magic number.
Which brings us to this really important rule. You only report the main SRS code once per lesion for the entire course of treatment. So what does that actually mean? It means whether the patient comes in for 1 session or 5 sessions to treat that same spot, you only bill that main SRS code 1 single time.
And finally, let's talk about the guardrails. These are the bundling rules that are going to keep your coding clean and accurate. Think of them as the final checkpoint to make sure you're not accidentally billing for things that are already included in the main code.
This is your do not report with list. First off, all that fancy computer-assisted planning, it's already baked right into the main SRS codes, so don't bill for it separately. Second, the code for applying a cranial halo, 20660, nope, that's included too. And third, any other stereotactic guidance codes are also bundled in. Just remember that the main SRS codes are basically all-inclusive packages.
So let's put it all together into a simple game plan. Here's your 4-step checklist for every SRS case. First, who's the provider, neurosurgeon or radiation oncologist? Second, classify the lesion. Is it simple or complex? That's your biggest decision. Third, confirm you're only reporting the code once for the whole treatment course. And fourth, double-check those bundling rules. Nail these 4 steps and you're going to be in great shape. To wrap things up, I'll leave you with this question to think about. After everything we've gone through, what's the single most important piece of information you need to find in that patient's report to pick the right code? If you can answer that, you're well on your way to mastering SRS coding. Thanks for tuning in.